name's Tamara Tudor, and today we're going to go over a bag valve mask, or a BVM. So in cases that would indicate you using a BVM would be apnea, cardiac arrest, respiratory arrest, and a respiratory rate of 8 or below. So let's talk about what exactly does a BVM do. So it forces air into the patient's lungs. There's a difference between oxygenation and ventilation. So oxygen is the act of the oxygen getting delivered throughout the body. So it travels through the bloodstream and goes where it needs to oxygenate all your organs. Versus ventilation, which as stated is the actual act of forcing air into the lungs, therefore causing carbon dioxide to exit the lungs. So this here is a BVM, okay? It looks like there's a lot to it, but there's not. We have the mask, we have the valve, we have a little spot here where we can insert a PEEP valve. We have the bag, the inlet valve, the oxygen reservoir, and we have the oxygen tubing, which you plug into this portion right here. Now, the other end of the oxygen tubing goes into a oxygen cylinder. Now, you want to have that set at a rate of 15 liters per minute, and that way, when you actually ventilate your patient, they get between 90 to 100% oxygen. So now we will move on over here to our patient. Okay. So here we have our patient, okay? Now let's say we get on scene and our patient is lying there on the floor. First thing we want to do, of course, is check for a response. Hello, hello, can you hear me? You're not getting a response. Now, you want to see if their chest is rising and falling. Okay, it's not. Do they have a pulse? No. So at this time, we can insert an OPA, okay? Because with an OPA, they don't have a gag reflex. Versus an NPA, which is a nasopharyngeal airway, that would go into the nostril when the patient does have a gag reflex. An OPA you can put in if they don't have one, which is a oropharyngeal airway. So we'll go ahead and insert that. And put the mask on, cover the nose and the mouth, and then form your C-clamp fingers. Now make sure that you have a good seal on the patient's face and go ahead and squeeze. Now you want to squeeze just enough to make the chest rise and then fall. If you squeeze too much, you're forcing too much air into the lungs, which can cause other problems, right? So nice and slow. You want to do every 6 seconds you want to ventilate. So once you squeeze, you want to count 1, 2, 3, 4, 5, 6. Okay, go ahead and give it a try. So we also have other airway options. We talked about the OPA and the NPA. We also have what's called an I-gel. With an I-gel, you just go ahead and insert that airway. We would just go ahead and insert it, and it would attach right here at the top. And then we can continue bagging with that in. But this way, you have much more control of where the air is going. where the oxygen is going. Because when you have OPA or NPA in, a lot of times you end up with abdominal distension and you come into the risks of your patient vomiting. Any questions so far? Okay. Would you like to practice bagging some more? Here, how about you put it together? Perfect, yeah. Come to the side so you're gonna reach. So this is much more effective because we can create a better seal. Okay, so I'm gonna have you step over here so you can bag, you can squeeze the bag. I'm gonna go ahead and place the bag. If you hold the bag, please. There we go. I'm gonna place the BVM. So you're gonna use your thumbs to push down here to create that seal. Now with the rest of your fingers, you're gonna gently grab the jaw and slightly lift. And this just helps keep the airway open as you're ventilating, and it keeps the seal. You can go ahead and ventilate, please. How often do you ventilate? Perfect. Ventilation is great whenever we have enough hands to do that, but a lot of time when we're ventilating, something's seriously wrong with the patient, so most of the time we need as many hands as we can have, right? In a cardiac arrest especially. So the nice thing with the eye gel or an ET tube would be that you have a much better we have enough hands. However, most of the time when we're ventilating someone, it's due to the patient being in severe distress, whether that is hypoxia, respirations below 8, respiratory arrest, cardiac arrest. So the cardiac arrest, especially when we have an advanced airway in, such as the eye gel or an ET tube, we can continue chest compressions while we're ventilating every 6 seconds, right? Which is wonderful because oxygenation doesn't really happen without the ventilation. Why is that, Kaylee? Okay, because without ventilation, we're not having oxygen being brought. There's no oxygen being introduced into the body, so we need the ventilation. And there's also no what coming out of the body? Carbon dioxide, perfect, yes, okay, great. So with pediatrics, you do want your respiratory rate to be, the respiratory rate is naturally higher than adults, right? So whenever we're ventilating a pediatric patient, instead of going every 6 seconds, we're gonna go every 2 to 3 seconds, okay? So same exact situation where we're gonna cover the nose and the mouth, and we're gonna create our C-clamp seal, and we're going to ventilate. Now, unfortunately, today I do not have a pediatric BVM. I have an infant and an adult. However, if you can see the size difference here, just imagine one being in between this size. Now, like I said before, there are different kinds of BVMs, right? We have, like I said, our adult, our infant, but we have pediatric. There is another one that's a little newer on the market. This one, you can, it actually goes like, I would say, it folds about in half, and it's a 3-in-1. It's an adult, pediatric, and infant BVM. So you have one BVM for every size patient. And as I stated, it's smaller so you don't overventilate your patient at once. All right, so some things that, common errors that people make when ventilating with a BVM, right? Improper seal, that's our biggest one. Some people think, oh, well, once I have my C-clamp and I put that on my patient and we're going 70 miles an hour down the road, it's just gonna maintain, that seal's just gonna stay. No, you have to constantly check to make sure that you have a good seal on your patient's face. You also want to ensure that the airway remains open. And once again, that is when your OPA, NPA really comes into play, but also just making sure that your patient's head is in the right position will make a huge difference. Another error is, like we talked about, the abdominal distension with all the oxygen getting pushed into the abdomen, because if you look at the anatomy, right, we have the trachea and then we have the esophagus. So they're sitting on top of each other. So when air goes in, it's not picking which tube essentially it wants to go in. It's kind of just going into both. So that's once again where the IJA really comes into play. It kind of blocks it off and forces most of the air into the trachea instead of the esophagus. Same with an ET tube. Really, our ET tube is the gold standard. That one goes directly into the trachea, forcing the air entirely into trachea. So as we are doing that, you really want to be cautious of vomiting. Let's say the patient does vomit while you're bagging. What would be something that would probably be a good idea to do? Yes, stop, for sure. Stop for a second, get your suction out, and go ahead and suction real quick, and then get right back to bagging as soon as you can. What would be a possible risk if your patient does end up vomiting? What could happen?
Could some get in their lungs?
Yes, exactly. They could aspirate. This leads to long-term issues. We would like to avoid the patient's already going through enough. Let's not try to make things worse. Aspiration pneumonia, especially in our elderly patients, can be detrimental. So definitely something that we need to be aware of. Do you have any other questions? No? Okay.